It's not working out like I want it to. Personal care skills. So this is things like hair washing, assisting with wound dressing changes, positioning your patients, the day-to-day stuff like the nuts and bolts of being a sterilization nurse aide. And so I can't really, it's not really awesome for me to sit here and just talk about these skills that you need to do. So believe it or not, this is not a long chapter for us. I'm going to hit some highlights that I know are important for you. One, maybe give you a couple tips on things that, like, I wish people had told me when I was in nursing school. And make sure we review some of the important parts, like these pressure points and bony provinces. And we'll look at some nasty wounds today. Kind of cool. Are you all into that stuff, like wound dressings? Haley, you're smiling a little bit. Why? Are you like, I bet you're the one that likes to watch Dr. Pimple Popper, aren't you? Oh my God. It's like I can read it like a book. My wife is that way. I absolutely hate it.
My daughter's like that. She loves it. I think it's disgusting.
I think it's fine if I was a doctor and I popped pimples for a living, I could do it. But I'm not like gonna go seek it out as extracurricular activity. I don't know. I just do not get that. And wounds are the same way. Like I'll do it. It's not something I love to do. Like some people are really into it. So wound care and wound prevention. Devices, we talked about doing the range of motion to prevent what, Emma?
Like certain stiffness and
What's the
not
word?
getting worse and being.
What's
I
the
can't
word?
think of it. I put my spot.
Anybody?
I'm drawing a blank.
Contractures.
There you go. Contracture. But also we got devices. So like, let me pull up the book here and fix my board real quick. This thing started working weird for some reason. Hang on a second. There we go. I switched my desk around and messed up my monitors. Okay. Now we're working. So what I'm talking about is we can do range of motion as preventative or as a maintenance, but we can also do something called like an orthotic device. Everybody may or may not have heard that term. And it may have been to an orthodontist and got braces where they fixed your teeth with an orthotic. It's the same thing, but for your hand or your foot. And you might see, it might look like this. One of these devices here. This says to be a real stiff brace that's got some hard plastic in it. It'll be made specifically for that patient. There's another one.
I can't see the screen.
Oh, I'm sorry. I had to start repairing again. Can you now?
Yeah.
So let me start over again. So here's one example of those devices. Remember I talked about Miss Brown who had a stroke and her hand was contracted?
Yeah.
They had to work it open, and she would get good movement in it after some work, a couple days of work, but we were supposed to be putting one of these in her hand every day. She didn't really like it because it wasn't pain. It was kind of painful getting in there. Then some patients had these because they were early in the contracture process, and they might have to wear this, let's say during waking hours, and take it off at night. Why? What's one thing I want to be doing if I have a patient? I walk in a room and I see a patient or a resident, I'm sorry, with one of these things going. What's some of the flags that should be going off in my head as an SRNA or a nurse about this device and what's going on underneath it?
She obviously must be hurting and trying to loosen something up, is why she's using it.
Well, yeah. Are they comfortable? Is this thing applied correctly? But I'm thinking more of what's at risk with this device?
A fracture.
Nope.
No.
Thinking more. Anybody else got any guesses?
Making sure that it's cleaned.
And when I'm cleaning, I'm looking at that skin, right? Making sure that skin
Oh.
is intact underneath there. Okay. That's why we're in school together.
Yeah.
What's going on with that skin underneath there? There's a story here in Somerset. Actually, I looked this one up on, I was trying to find a place to do clinicals for a class like yours. And Somerset, it's not Somerset Nursing and Rehab, it's the one that's in the old hospital down, those two weird streets in Somerset that kind of like this, downtown. Well, it's where the old hospital used to be. It's now a nursing home. And they were tagged to where they wouldn't accept Medicaid SRNA clinicals. They had a tag. They got in trouble with the state survey. And I was like, well, what's going on? So I went and looked it up. And turns out they had a patient who fell and broke his knee or something. And he had one of these devices on his knee. And he got sick after a few weeks. He went to the hospital and like got that all taken care of, and he come back to the nursing home, was fine. And then after a few weeks, he had to go back to the hospital for like dehydration. Well, when he got to the hospital, they took that knee brace off, and underneath his knee, underneath there, somewhere was a wound like this, something like this going on, a pressure ulcer, where nobody had thought to take that knee brace off and either during a bath and to wash in that area, but most importantly, to look at that skin and make sure it's intact. And nurses have been signing off on skin inspections done every 30 months or 30 days, and SRNAs have been signing off on bath was complete, no new skin areas. And so they just went back and got them all. And that facility got a tag, and they started looking at all their skin inspections because everybody was checking off, oh, this is great, but they weren't doing what they're supposed to. And part of it was everybody was like, well, I don't know if we should take that off. The surgeon's supposed to deal with that thing. And two, his knee's broke, that just needs to stay on there. Somebody will take care of it. And everybody kept passing that buck along. So a nurse should have called someone and got it fixed. And the SRNAs should have been bugging the nurses or mentioning to the family when they saw him in there, hey, we need to do something about this. And it could have prevented that. Like, you gotta be pushy sometimes. So don't, if you walk in a room and something's like, you're like, oh, that kind of is just sticking out to me. Stop. What is going on here? Something's probably trying to tell you something, your gut. I'm not preaching to you. This is all part of personal care stuff, like just being aware. We get around patients every day and we work with them every day, and you get close to them and you stop looking at the whole picture and you start to miss stuff. You know what I mean? You've ever lived with somebody, was away from them for a long time maybe, and come back and you're like, man, I never realized they were insane or they were depressed or something like that, because once you get so close to them, you don't see the forest for the trees. You gotta stay vigilant on stuff like that. So let's just back up here a little bit. I think everybody can pretty much appreciate the idea that, hygiene and grooming is going to be part of your daily routine. Bed baths, how often do you give a bed bath usually, Linda, to one resident?
What was that?
When you give bed baths to your residents, how often do they, well, let's see. So you're not doing an SRNA job, but you are, what are you doing again? Remind me.
Well, I am now, but at first it was just the CNA.
You were hired
which
and went through their
is,
training.
huh?
You were hired and went through their training.
Yeah.
Can you all hear me okay?
Yeah.
She acts like she's having a hard time hearing me. Okay, so how often, I was just making sure, I was asking you a fair question. How often do you give one resident a bath? Usually.
A regular bath in the tub, 2 to 3 days.
2 or 3 days. So people don't take showers in the nursing home like we do every day, because their skin gets dry, and if you wash them too much, it will dry out. And so it's a good thing that we only give them complete baths every 2 to 3 days. Now, some little ladies might try to take a shower every night. I've had those, and that's fine if that's what they want to do. Some patient might not ever take a bath, and you have to fight them just to get a little bed bath, like a wipe down. Like we do partial bed bath. Sometimes that's all you can get. But hygiene mainly consists of a bath every 2 to 3 days. So that leaves you, what hygiene is left over for you giving a resident? Well, one that's often forgotten are dentures. Everybody kind of neglects the dentures. Cleaning those, making sure they're fresh before you put them back in. And then what would be most important would be perennial care and looking at their skin. So what are we looking at when we're looking at skin? We want to make sure we got a good skin color. What's a bad skin color? Well, one that's going to make us concerned.
Red.
Yeah. That's one color, because red means there's inflammation going on. What accompanies inflammation, Haley? What's usually going on? Say you have a little spot that's kind of red and raised. What else accompanies that type of spot?
Infection.
It could be an infection. What do we see on your skin when we have an infection?
A rash.
So what's the signs and symptoms? I'm asking. That's not a good, I'm not asking it in a good way. Signs and symptoms of infection. We're talking about skin, okay?
Okay.
Redness. What else happens?
Does it get tender?
Yeah. Tenderness or pain. I said raised. That means swelling, right?
Mm-hmm.
And then warmth. This is what I'm looking for. Warmth. red, hot, angry, things like that. We know that's a problem when we see that. So we talked about pressure wounds. Whenever somebody, when does a pressure wound start? When can we say, hey, they've got a pressure wound? If you can, say you're rolling a patient over and you're looking at their backside. If you see a red spot and you can touch it and it blanches, it becomes white, then that means it's not a wound yet. Because if you blanch it and blood is pushed out, like if you can push down your fingernail right now, real tight, it's going to be white, and then it'll turn pink again, right? That's blanching. If it doesn't blanch, that means that it's inflamed and that skin is actually red, and it's a wound at that point. So if it doesn't blanch, it's a wound. You can just kind of put your finger on it. And we know these happen on bony prominences, areas where skin is thinner and bone is a lot more sharper. And here are some of the places for it. They say elbows, hips, knees, inner and outer. I don't really know about that one, but I'll write it down. Shoulder blades is one. Ankles is probably, I probably should have ranked this from what I think is, or what I've seen the most. Ankles happens a lot. This part right here on the outside, that bony prominence. Heels is probably the worst offender. The tops of your toes, or for the residents. They say back of head. I've even seen around the ears here where they might wear oxygen tubing constantly, and it will wear a hole in the back of their skin behind their ear. Then that's a pressure wound if it's caused by something rubbing it or sitting on it. So people who have diabetes and poor circulation in their lower extremities, these are bad news for them. These lower wounds here. And then the ones everybody thinks about when they think of pressure wounds are your buttocks. And those bones are the ischial tuberosities.
Am I the only one losing vision? Like my whole screen went black.
You might just have like a bad connection for a minute. Everybody still with me?
Yeah.
Mm-hmm.
So let me go find you a picture of what we're talking about, ischial tuberosities here.
Is it storming over there in Somerset?
No, it probably will be though.
Yeah. It was terrible here,
Ton
off
of,
and on all day yesterday.
okay, so I'm looking at a pelvis here. And this is the front. This is like you were looking at somebody in the face. What's that called? The what? Well, it's right here, I guess. Anterior view. And this is your butt bone right here. And this whole bone is called the ischial, and it's a tuberosity, meaning it's just like a bump. ischial tuberosity. So people who sit in a chair all day long, this is what you're sitting on. And you can see why that would be a problem, right? Agree? Now, also up here, we have this peak. This is your ilium. And if you were to feel your hips right here, this is the iliac crest right here. And on the back side, kind of high, you'll get a wound here often. Everybody follow me where I'm at on that?
Yeah.
And then there's other places like the coccyx and things like that. And here's what some of those wounds look like. So here's this, and I'm going to talk about this in a minute. We stage wounds, and I'll tell you how we stage them here in a little bit. But you can see this is red. If you pushed on that, it wouldn't blanch. This is what we call a stage 1 wound. I would take maybe a couple notes on this. So stage 1, make sure I'm giving you the words that you might see on an exam here. All right, skin is intact. But may look red. And actually that term is called erythema or redness. And if it's a dark skin like a black person, it might be kind of ashy or gray looking or just a different color. It could be swollen, it could be painful, firm, soft, warm or cooler when compared to the area around it. Okay. So what's happened is that top layer of skin's been injured. Here we see stage 2. That picture big enough for you all to see it?
Mhm.
This is a partial thickness. And partial thickness skin loss involving the outer and or inner layers of the skin. Okay, so it's only in the skin. Guess what? Stage 3 goes below the skin. This is a full thickness. Right here is what we're talking about, the heel. Meaning the whole area, your epidermis and your dermis have been penetrated. And fat is visible or adipose tissue. May or may not be visible. Most of the time it is. Something called slaw or eschar tissue may be present. Slaw tissue is like, let me find you a better picture on Google here. Soft tissue is that yellow goobery stuff that happens. Here's a good one. There's a good one. And usually people who treat these like nurse practitioners and stuff, they'll come in and take that off on a regular basis. Or certain dressings can go on it like a wet to dry, maybe silver nitrate, or a little bit of what smells like bleach water can go on it. And it will dry that up and allow healthy tissue to start growing in there again. It's really interesting to see how these things hook together in the process of healing. Okay, so that's pretty much stage 3. Oh, I'm sorry, SR tissue. I didn't talk about that one. I want to show you a picture of it too. SR tissue is just black, dead tissue. It looks like when you've been frostbitten or something. There's a great example of it. This is not a scab. This is tissue. It's died and become real hard. And this is really attached underneath. And so one way in certain patients to promote healing is to go into surgery, debride this or scrape it all out and cause bleeding, which will bring in new tissue new cells, new growth, new nutrition, and maybe it'll heal better. They'll take it in and debride this in surgery. Okay, so stage 3. And then the last one, well, not the last one, but almost last one, stage 4. This one is full skin, and it goes all the way down to muscle, bone, tendons, anything that's underneath your skin and fat. Sometimes these structures are visible, sometimes they're not, but they are involved with the wound and dead tissues happening on these layers now at this point. Looks like a deep crater. Slaw and eschar could be present here too. But usually you can see a structure underneath. It's interesting. Sort of is, isn't it? What is that? I think this is a butt here. And this is the small of their back. And so you can see this crater here that looks something like an ulcer. This is a good example. These right here. This is looks like somebody's butt. And so the coccyx here. It's not really a good picture of a stage 4 wound. It may be bone. Here's a good one. So you can see some tendon underneath here. I just wish I knew what area this was. It looks like a heel maybe or something. And I've seen wounds this bad and we've healed them up. It took one patient who had a crater like this in their butt. It took us 2 years to finally get him healed up. Every day, going in and changing the dressing. And doing a few other things. Because it's a lot of tissue to be built back. Lots of surgeries of debridement and causing new growth in there. So you can be a wound nurse and just do these completely. That's your whole job. And there's doctors, usually they're plastic surgeons, take care of these wounds and treating them. But it can be an interesting field. Like I said, you go into a resident's room and they know you're there to do their treatment. It's hard sometimes not to look like it's grossing you out or it smells bad, but you don't want to offend that resident and make them feel bad. So you just got to kind of put on your straight face and do the job and get out of there. But sometimes you might be asked to assist with these dressing changes, and that's well within your scope of practice. Sometimes they're sterile, sometimes they're not. If you go in there and you can understand why it would be so important to keep this area clean if this patient was incontinent, right? Because urine and fecal matter is just going to kill this tissue underneath here, and it's just going to take off in terms of getting worse. Any questions? Any thoughts about that? So how do we prevent some of these? And how do we get patients better from it? What's one thing I want to make sure is important, if you can guess? You may not know, and that's okay. Say I got a patient that's healing with something like this. Other than turning them and making sure the wound is clean and that they're clean, what's another thing I can be thinking about to help them heal? Let's see how nurse mode you all are right now.
I keep thinking motivation, like just overall mental health.
Yeah, if they don't want to get better, they won't, right? Their body sometimes won't respond.
Right.
Melissa, what has to happen in here? New tissue has to be built, right?
Right.
Where do we get the stuff to build new tissue from?
Our diet, so increase
diet.
protein.
Yeah, there you go. Somebody remembered something. Make sure they're getting enough protein in their diet. Make sure they're eating, period. I mean, milk has some protein in it. Nutrition is going to be critical. And then the second and probably most important part of that is getting them turned and taking care of that area. So I'm doing 540. I'm right on time. I'm doing great here. I'm not going to try to worry about telling you how to wash someone's hair. We'll practice that in lab, and everybody here has washed their hair at least once in their life, probably. How to do a back rub. I hate doing back rubs. Bed bath we will practice together for sure. So you'll see in your care plan, remove wrist orthotic every day for 2 hours, or remove and observe skin underneath, and you'll have to admit beside it that you did that. Okay, make sure you're doing that stuff actually, and don't take anybody else's word that they did it. You always confirm, right? Well, I looked at it earlier today. It was fine. I'll just confirm that. Thank you. Basically, with the full bed bath, when we review it, it's just like washing your hands. Anywhere there's a mucous membrane, like your eyes, all the strokes when you're washing them will go away, and you'll find a new area of the washcloth, and then start in and go out away, so you're not bringing bacteria into the eye. Pretty easy to get down. Catheter care. We talked about why this is so important. Urinary tract infections, right? Did I tell you about a catheter bag and what I want to see with that when I'm walking down the hallway looking in the rooms? Not sure if we talked about that. Might be in the last class. So I'm walking down the hallway and I've got rooms on each side. And I can look in and see the residents either in bed or watching TV or doing their thing. Is it very appropriate for me to see a bag of urine hanging off the bed? Probably not. This is actually a dignity issue. If they're in a wheelchair and they have an indwelling catheter and they're going down to the dining room,
these will often, the bag will come with a flap that will cover it up. That's a big hit. It's a dignity issue, and they'll get you on that. The inspector will come in and be like, hey, why am I not looking at a covered bag there? Some patients don't care. Residents don't care, but it's the rules, and that's what we got to do. So you want to make sure these are always hanging on the bed and they're not on the floor. Okay? Because it's already a challenge enough not to keep bacteria out of their urinary tract, right? We have to keep this clean on the outside. We definitely don't want this on a dirty floor in a nursing home. That's one of the things you check. They've got their call light near them. They've got water to drink. The catheter is not on the floor. And when we give perennial care here, pretend there's no catheter. But the same thing happens. We usually go from the area that can get contaminated away from it. We wash starting in the area and then away from that. Same here. We're going to wipe away from the meatus or the urinary tract opening. And if you were, when we practice giving cath care, you can just imagine those pictures with a tube coming out of them. Same way, you're going to do one away from the urinary tract with good soapy water. I've never seen a patient really actually like these things. Every nursing home I have them, they're like $5,000. And the couple patients or residents that's been put in it, either by their family trying to insist that they get in there, they're like, oh, I'm going to drown. Or it takes so long to fill up and they get cold, they hate it. But you might come across someone that wants to get in there, and it's like a sauna bath. It's lots of jets and stuff. They're kind of dirty though, in a facility with 80 people, and I don't really trust anybody to clean that. I know I wouldn't if I was going to get in it. I'm not saying that anywhere you work at is going to be dirty, but this is a shower chair. You will use this because a wheelchair, you don't want to wheel it into the shower and soak it down, right? Patient may not be able to stand, but they got to get into the shower. And so we'll put them on this thing. It's made of plastic, and it can just stay in there when you're done. And usually people will get their own shower chairs. Sometimes there's a community one, and we'll just make sure it's cleaned after we use it. It's hard plastic. It's easy to clean. Moving on here, I'm just kind of flipping through things. Fingernail care. This is what you do. I mean, it needs to be done, but when you got caught up and you're all just sitting and chatting, I'm not saying you're going to do that at work, but I would go look at people's fingernails. This is something that can be done in the downtime often. That's stuff I'm looking for when I'm in a nursing home. Is their hair cut? Are they shaved? Are their fingernails dirty? My son Henry is only 4 months old. Somehow his fingernails get crazy dirty every day. I don't know what he does. He's not like outside playing in the dirt. I'll have to scrub underneath them at night. It's just a good sign for your residents when they don't have dirty fingernails, right? Kind of stuff that's easy to overlook. In terms of clipping them, everybody's like, I don't know if I can do that or not. I'm an SRNA. You can clip them. If you're afraid you're going to hurt them, then just ask someone else to do it, like a nurse. If they're diabetic, I would not clip their toenails. Okay? Because if you risk injury to that cuticle in there or something, it can turn into one of those wounds we were just looking at if they're diabetic. Everybody still hanging with me here?
Mm-hmm.
Melissa,
Yeah, I'm here.
you look like you're about to fall asleep on me. Combing hair is not a huge task for anybody, I don't think. You can shave residents, no problem, with a regular razor or electric razor. If they're on Coumadin or blood thinner, you usually see an order that says do not, or electric razor only. because it's really hard to make somebody cut and bleed with an electric razor, right? They're kind of got a safety guard on them. A regular razor, though, it can start bleeding and be a pain to quit. Everybody knows what blood thinners are for and stuff. Strokes, gonna have that, or prevention of clots. Here's that thing. That was a test question, wasn't it? Which side do you, when undressing a resident, start with the stronger unaffected side? Did y'all see that question?
Yeah.
I think it may come up again. And then finally, if a resident has a tube going into them, whether it's a catheter, a gastric tube, or an IV, please know you should not be pushing anything into that or taking it out. If it comes out, don't panic. If they were that fragile and it would kill them if a tube came out, they wouldn't be in the nursing home. But you want to address it fairly soon, okay? But you don't have to like, oh my gosh, this is the end of my life and their life. It's not like that. IVs get pulled out accidentally all the time. G-tubes get pulled out. Catheters get pulled out. Just be cool. Let the nurse know. One thing a lot of people do, my nurse aides, they'll be in there working on the resident, turning them over and everything, and they have a G-tube in. The pump that's giving them their feeding. So some people who can't eat or swallow, they'll get it looks like an IV bag. And this will be like maybe 2 liters of stuff that looks like a nutrition shake in there, but it's not that. It's really like a medicine type food. And when you turn patients over, sometimes this will get kinked and the pump will get mad and start beeping. And if you just straighten it out, it would quit and go on its way. But the aides, because they're doing a lot of work in there and they're going to have them turned over for a few minutes, will silence that alarm and turn the pump off, finish their job, and then walk out and walk away. And then I'll come in 2 hours later and they've missed 2 hours of feeding, which might be like 60 mLs of this liquid in there. That might be like 400 calories they're not getting in their day. That's a big deficit for them, for somebody who depends on this for their food, right? So just be aware of that. We will work on applying stock, because we talked about why we use those to compress that blood flow in there. And then hopefully everybody here knows how to brush teeth. What about unconscious patients? Linda, you still there?
Yeah, I'm still here. I'm watching you on my phone, but I can hear you on my laptop.
That's fine. I was going to ask you if you ever took care of somebody that's unconscious or on a vent.
No.
So what I got to worry about when I'm providing oral care on an unconscious patient, Emma?
You need to make sure that getting everything like out of their mouth and clean and keeping it like moist and not drying out too fast.
That's exactly right. If they're breathing, dry mouth causes decay, just like the patient who's on hospice care. They're doing a lot of mouth breathing. You want to make sure it's moist and clean. What's another thing I'm really worried about? Probably second, Emma, on the list that I'm thinking of. Patient who's asleep and is never going to wake up. What am I worried about when I'm brushing their teeth and stuff?
Making sure like nothing goes down their throat.
Yeah, their airway. Protect their airway. So when you go in to do your skills test and you get oral care on the unconscious resident, you're still going to brush your teeth with a small amount of water, and you'll take a little sponge and wipe that out. But when they set the supplies out for you to do this task, there'll be like a little bottle of Listerine included with it. It's just part of like an oral care kit. And everybody gets confused. They're like, oh, I need to do something with this Listerine or this mouthwash here. Do you ever put liquid in the mouth of an unconscious patient? No, never, never, ever, ever, ever. And they won't try to trick you. It'll just be sitting there, and people get nervous and start trying to do stuff with it. Just ignore it. It's just there, okay? Don't put it in the patient's mouth. Aspiration, Emma, is the word for what we talked about. This is something going in your airway, whether it's food or water. Aspiration. They might aspirate. Another thing we do on an unconscious patient is we turn them on their side before we start giving oral care. That way the liquid and whatever's doing can kind of drain off the side of their cheek and not down straight down the back of their throat. That's an important step. So, Haley, do you think if you're going to go in and do oral care on an unconscious patient, do you remember those first steps and the skills that you've been memorizing? Can you tell them to me?
To knock on the door and wash your hands.
What else you got to do?
I don't remember.
Is
Anybody
it
else?
your meet and greet?
Huh?
Your meet and greet?
Identify and introduce yourself,
Mm-hmm.
and provide for privacy.
Right.
Knock on the door, wash your hands, identify, introduce yourself, provide for privacy, and the one I just forgot that I mentioned a second ago. Are you going to do that for an unconscious patient? Is it going to be necessary, Melissa, to introduce yourself?
Well, yeah, you'd still want to speak to them just like any other resident.
That's right. You want to pretend that they can hear you in every word you're saying. Very well. Very good. Very good. Everybody knows how to floss, hopefully. Hey, did you know if you don't floss, I bet there's 2 people out of this group. 40% of the surface area of your teeth do not get cleaned. That's almost half, right? Because you got a tooth, but it's not a flat surface. It's 3D flat surface. So when you're brushing, you're only getting like these sides right here. You got to get these sides with floss, okay? FYI, if you want to keep your teeth like your 70s or 80s. Talk about bedpans when we get together in the lab. This is like those colostomy bags. You want to make sure you get it right the first time so you're not ending up with a mess. I will tell you, the wider end goes up, just like a toilet seat, okay? I think that's a test question in case nobody can figure that out. Urinals sometimes are used by men. These things are sometimes old men will want to. They'll get one when they get into the nursing home. You'll give them a urinal because that's just like the thing to do for the new patient that just got there. You don't know if he can get up and walk by himself. So instead of him getting up and possibly falling, they're going to give him a urinal. Well, the guy might be able to walk perfectly fine, or after a couple of days, he might have been evaluated, and everybody's like, "Okay, you're free to walk around and go to meals on your own, do all that stuff." Well, then he's still going to use this because in the middle of the night, old men get up and sometimes need to use the restroom multiple times. And it's more convenient for them to just pee in this thing and put it up on their nightstand and not go to the bathroom. It's kind of a problem because one, it makes them kind of lazy to where they don't want to get out of bed. And I'm not really meaning lazy in a mean way. Is that helping them with retain their normal function, or is it kind of making it not as good as it could be? It's kind of keeping them below the level of what they could be doing, right? You gotta, use your judgment on that. But these don't always have to stay in the room after the patient's been admitted. And sometimes it's just gross and tiresome to be emptying a jar of pee every day, 100 times a day. when they could be getting up and using the restroom. It's more sanitary and it's better for them. Sometimes patients will need to use a bedside commode. This may be one of the first things you get for those residents that are admitted. You don't know if they can get up or not. Either you can look at them and they're maybe obese or they might have an issue or they can't get out of bed on their own. You're going to make sure this is in the room before they even get there. And then you can transfer them just like you would to a wheelchair, straight from the bed to there. And once they sit on it, you can take this part out, just go to the toilet and dump it in there and then put it back in there, and it's said and done. It's easy to clean and things like that. So let's look at these positions. I think this is the last thing we're going to talk about here. I don't think we've covered these in other ones. We did abduction, adduction, things like that, but we haven't talked about prone and Fowler's and stuff in depth, I don't think. Is that right?
Yeah.
I mentioned Fowler's in one of the lectures. So lying on your back, that's supine. I'm going to write in parentheses here to kind of describe it. But you should know this, just like abduction or adduction. Linda, what does abduction mean? Just pop quiz here.
Abduction is inward.
Towards the midline. No,
Yeah.
I'm sorry. No, that's incorrect. I'm sorry. Abduction, you're abducting it. You're taking it away.
Oh, okay. Yeah. I need to remember that.
Adduction, you're adding it back to the midline.
Okay. I actually just got done reading that.
It takes a little bit of practice. So this is supine, and you can even call this one of the movements. We don't really go into it in this class, but like if I'm going to take my hand and turn it over, that's called supination. I'm laying it on its back, sort of. And that muscle that makes me turn my arm like that, it's called, there's a couple of them in there to do it, but one's called the supinator. Allows you to turn your arm over. The opposite of that is the prone position. This is lying on your stomach. How many people lie on their stomach when they sleep? I don't, but I don't even know how I lay when I sleep. Just go sleep. And just, this is FYI, but when you turn your arm over, it's called pronation. And there's a pronator muscle in there. Okay, so supine and prone. The Fowler's is sitting up at 45 degrees. So other than people and their breathing, what's another good reason to keep people like this, do you think? What about those that have acid reflux? What about those that are on G-tube feedings where they don't eat, but they're constantly having liquid pumped into their stomach? You don't want that coming back up and going down their airway, which is called what, Emma?
The aspiration.
Yeah, we don't want them to aspirate. So we keep their head of bed always at 45 degrees. And then the last one is called the Sims. And it might help you to remember to call this the recovery position also. And this bottom one right here is Sims. What's specific about it is that you're lying on your left side. Okay. So why is this a thing? Well, let's look at our lungs for a second. When you have your trachea coming down your midline here, you can go to the right, you can go to the left. What's on the right side of your body near your lungs? What's that organ that pumps all the time?
Your heart.
Your heart. So your heart is kind of situated over here a little bit behind your lung, and it pushes things out of the way. So this bronchial tube right here is shorter on the left. I think it's longer. I'm sorry. No, longer because this lung is down here. This tube is shorter because this lung is longer and a little bit bigger. It has 3 lobes on it. 1, 2, 3. This one only has 2 lobes. 1, 2. So when people are vomiting and they're not conscious, this is usually fluid will come straight down this tube right here because of the way it's positioned. It will go straight into their lung. Kind of goes the big curve here, but this one goes straight in there. So if they're on their left side, that keeps fluid. It kind of protects that right there, and fluid tends to go this way if they happen to get something in there. So if you get somebody drowning, it'll say do CPR and then turn them on their left side in the recovery position. Or if you're in surgery and somebody's under anesthesia and they start vomiting, you automatically put them on their left side to prevent aspiration or try to prevent it. And that's why this is called the left side or SIMS recovery position. That's where all that comes from. And then their leg is up. So this is a good position to do like enemas, I think suppositories. And especially with their leg up, it allows the insertion of those things. All right. Kind of talked about that. Talked about transferring. There's all kinds of different devices that transfer people. What was the one we talked about the most that you should have on you at all times? So like your plumber's belt.
Gate belt.
Gate belt. Very good. We talked about which side to lead with. Lifts are a big part of your daily job. And we don't even teach you how to use them in the course because every facility you go to is going to have a different type of lift and it's going to work a different way. And they're going to train you on it in the way they want you to know. So we can't cover all those. So we just give you a brief overview. But we don't even practice doing it in the, like we don't go out and buy a lift for y'all to practice on because everyone's going to be different. Just make sure you're not screwing around when you're using it and drop a patient. Pay attention to what you're doing, right? Make sure you put these harnesses on the correct way and don't try to wing it or get in a hurry. That's it. A lot of patients get dropped from these things. All right. I appreciate y'all listening to me. I'm right at an hour here. I'm going to end it there. I'm going to post this exam tonight if y'all are comfortable with that. It's been okay for you so far, not too hard.
Mm-hmm.
If anybody just completely bombs or something, we'll take another look at it together. But just do that for tonight. And then we will meet tomorrow and go over vital signs. It's a little bit, it's kind of a better chapter 2. And, only a couple more days and y'all are done with this. So hang in there.
Okay.
All right. If you need anything, let me know. Otherwise, I will see you tomorrow at 5 and I'll send that invitation out here as soon as we hang up.
Okay.
All right.
Thanks.
You have a good
See you
day.
tomorrow.
Thank you.